Welcome. I'm Terry Tropin, and today I'll be discussing the 2023 update for CPT's Evaluation and Management Code. In part 2, I'll be talking about medical decision making. But first, let me tell you a little bit about myself. I have a master's in Healthcare Administration Informatics from the University of Maryland Global Campus and have RHIA and CCSP certifications. I am also an HEMA-approved ICD-10 trainer. I taught health information technology at Montgomery College in Maryland for over 20 years. I also have written books on coding. These books are study guides that summarize the coding guidelines. I developed them for my students, and I've now put them into the books. My books include one on E&M coding, ICD-10-CM coding, and ICD-10-PCS coding. These are available on Amazon. The CM and PCS books have been updated for 2023. The E&M book will be updated this fall. If you would like to purchase a copy of the slides for this video, give me a thanks of $5 or more and comment with your email. I will send a PDF of the slides. Click the thanks button under the video. Also, I would ask that you like my video and subscribe if you're not already a subscriber to my channel. Okay, so here is what I'm going to talk about today. This video covers changes to medical decision making, including general guidelines and the 3 elements of medical decision making: number and complexity of problems addressed at the encounter, amount and or complexity of data to be reviewed and analyzed, and risk of complications and or morbidity or mortality of patient management. Now, if you look at part 1 of this update, that includes changes to the key components and general guidelines. Part 3, which I haven't put up yet, will be on changes to specific categories of code, such as observation codes. So this just deal with medical decision making. Let's start with changes to the guidelines. Now, the part that is underlined here is words added to the paragraph. The part that's crossed out is part that was deleted from 2022 to 2023. So, general guidelines: when the physician or other qualified healthcare professional is reporting a separate CPT code that includes interpretation and/or report, the interpretation and/or report is not counted towards the MDM when selecting a level of E&M services. Now they change should not count to is not counted. It's a little more definitive, I guess. Note also that the wording's been changed from level of office or other outpatient services to level of E&M services. This is because the separate guidelines for outpatient services and other services have been combined into one set of guidelines. The differences between outpatient and other services have been eliminated. This guideline means that you can't double dip. If an interpretation of a test has its own code, you can't count the same interpretation using a code and count it as part of the medical decision making. That will be counting the same service twice. Can't do that. Okay, here's another change to a general guideline. This guideline was also designed to prevent double dipping. So when the physician or other qualified healthcare professional is reporting a separate service for discussion of management with a physician or other qualified healthcare professional, the discussion is not counted towards the medical decision making when selecting a level of E&M services. Again, office or other outpatient services was crossed out, made more general to E&M services. So the last guideline we talked about dealt with double dipping for tests. This deals with double dipping for management of a discussion of how to manage a patient. So if the discussion is reported with a separate code, then the discussion can't be counted again as medical decision making. So Table 2 has been changed to Table 1. Now that's the table that has the each of the 3 categories and then what elements are included in straightforward, low, moderate, high. This says the levels of medical decision making table is a guide to assist in selecting the level of medical decision making for reporting. Again, they crossed out the office or other outpatient service and added, it just made it E&M services. The table includes the 4 levels of E&M, of MDM, and then they crossed out C level 2. So this is not really, this is kind of a formatting change and not really a big change. But they did add this to the general guidelines. This wording was added for clarification. So they added examples in the table may be more or less applicable to specific settings of care. For example, the decision to hospitalize a patient applies to outpatient or nursing facility encounters, whereas the decision to escalate hospital level of care, e.g. transfer to ICU, applies to the hospitalized or observation care patient. See also the introductory guidelines for each code family selection. So this is just kind of clarifying changes in escalation and care, outpatient or nursing facility to inpatient, inpatient to ICU, for example. That's what this is just kind of a clarification. Okay, so let's look at each of the elements of medical decision making, starting with number and complexity of problems addressed at the encounter. So they changed the definition to problems addressed, so this whole category. Problem addressed or management is evaluated or treatment, but the added wordings are down here, starting here. For hospital inpatient and observation care services, the problem addresses the problem status on the date of the encounter, which may be significantly different than that on admission. So after the patient is admitted, the problem can change, hopefully get better, maybe not, but it doesn't stay the same necessarily. It is the problem being managed or co-managed by the reporting physician or other qualified healthcare professional and may not be the cause of the admission or continued stay. So the patient may have been admitted for something else and now they're addressing a new problem. The patient their stay may be continued because of a different problem, not necessarily why they were first seen. So let's look at the medical decision table. Under problems addressed, 2 things were changed, 2 factors were added to number and complexity of problems addressed. To the low level, they added 1 stable acute illness. Also to the low status, they added 1 acute uncomplicated illness or injury requiring hospital inpatient or observation care. These new elements are defined on the next slides. Okay, stable acute illness, a problem that is new or recent, that's why it's acute, for which treatment has been initiated. The patient is improved, and while resolution may not be complete, is stable with respect to this condition. Though this is a condition, it's being treated, so far so good. It's interesting that this doesn't include examples, but everything's going okay, but the patient is not completely cured of the condition, but it's going well. Here is another condition. This acute uncomplicated illness or injury requiring hospital inpatient or observation level care, a recent or new short-term problem with low risk of morbidity for which treatment is required. There is little to no risk of mortality with treatment, and full recovery without functional impairment is expected. The treatment required is delivered in a hospital inpatient or observation care. This is a condition much like the last one, but treatment must be delivered in a hospital or inpatient or observation setting. Again, no examples are listed. I would suggest if patient has an infection that's going to be taken care of, but it requires intravenous medications over time, therefore it's done in a hospital observation or inpatient, that would qualify under this definition. Okay, also, they changed the definition of problem addressed, minimal problem. This was already in here, but they just revised it slightly. It's a slight change, but it's an important one. Minimal problem, a problem that may not require the presence of the physician or other qualified healthcare professional, but the services provided under the physician or other qualified healthcare professional supervision. Previously, it just said C99211, but they've added 99281. This is a revised code, important revision. 99281 is an emergency department visit, and they've added the wording, this may not require the presence of a physician or other qualified healthcare professional. So that's a big change. They deleted the, which requires these three key components, because we don't do key components anymore, but they've added may not require a physician. So this is one of those small changes that can be really important. Also, for problem addressed, they changed the definition of a stable chronic illness. So all they did with this one was delete the examples. I think that the example is kind of, people thought that if they didn't have one of these, they couldn't use one of the things listed in examples. You couldn't use this one, so they just deleted the examples. So acute uncomplicated illness or injury, this was also changed. Again, the examples were deleted. Okay, chronic illness with exacerbation, progression, or side effects of treatment. This was also changed. The chronic illness is acutely worsening, poorly controlled, or progressing. So this is important information to help kind of define the condition here. A chronic illness is acutely worsening, poorly controlled, progressing with an intent to control progression and requiring additional supportive care or requiring attention to treatment for side effects. This is terrible wording. What it means is the chronic illness is acutely worsening, poorly controlled, or progressing. Treatment is aimed at controlling the progression or worsening of the condition. Treatment will provide supportive care and treat side effects. So they've crossed out this first sentence, and they've made it much more explicit. Okay, the definition of undiagnosed new problem with uncertain progression has also had the examples deleted. The rest of it is still the same. So acute complicated injury, they crossed out again the examples. Okay, chronic illness with severe exacerbation, progression, or side effects of treatment. Now, this is an interesting change. The word hospital was deleted and the word escalation was added. So any increase in care, rising of the level of care, could be represented here, including from outpatient to inpatient care, observation care to inpatient care. So it makes it more general. It's not necessarily change within the hospital. Okay, acute or chronic illness or injury that poses a threat to life or bodily function. First, the examples were deleted. Then wording was added. Some symptoms may represent a condition that is significantly probable and poses a potential threat to life or bodily function. These may be included in this category when the evaluation and treatment are consistent with this degree of potential severity. So this deals with symptoms that may indicate a condition that is very likely to be present or to occur that would pose a potential threat to life or bodily function. So the symptoms indicate something, a condition that is a real threat to the patient. Okay, so let's move on to the second element of medical decision making, amount and or complexity of data to be reviewed and analyzed. The guidelines added a new phrase. You see this here underlined in the bottom, not separately reported. Again, this means a discussion captured in another code cannot also be used for medical decision making. This is the double dipping issue again. They've also added a sentence to the definition for independent historians. They've added the phrase, it does not include translation services. So an independent historian is not just translating the service of the patient's words. It's an individual patient, guardian, surrogate, spouse, witness who provides additional history. It's not just translating, it's providing information. Okay, independent interpretation. They've done some changes to this one too. This interpretation is performed by another provider other than the one who actually performed the test. So the provider is looking at test results from another individual and interpreting them. So that's what this is saying. This does not apply when the physician or other qualified healthcare professional who reports the E&M service for the test doesn't apply. A form of interpretation should be documented but need not conform to the usual standards of a complete report. It doesn't have to be the full report, but it has to be a viable interpretation of the report. So you can count an interpretation for a test that your provider performed, but only for an interpretation that your provider performed that was the test actually done by another provider. So again, a clarification. The final element is complication of risk of complication and morbidity or mortality of patient management, the final element in medical decision making. The guidelines have been revised. This includes decisions made at the visit to encounter, associated with the patient's problems. So what we're talking, it's kind of clarifying that it's not the problem, it's the procedures and treatment, the risk of the procedures and treatment, not the risk of the problems. That was kind of done in one of the previous elements. So definitions for this component have also been revised. First, look at drug therapy requiring intensive monitoring for toxicity. It's interesting, they've eliminated some of the examples, but not all of them. So we've kept an example may include monitoring for cytopenia and the use of an antineoplastic agency between dose cycles, but crossed out are the short-term intensive monitoring of electrolytes and renal function in a patient who's undergoing diuresis. Now they've made changes to the table for the risk element. Added to the high risk column was parenteral controlled substances. So let's look at the definitions of controlled substance and parenteral. So this is added to high risk. So parenteral, you should probably know, substances administered given by a route other than the alimentary canal, outside the gastrointestinal system. This could be subcutaneous, intramuscular, intravenous, intraarterial, intradermal, etc. But what is being administered is a controlled substance. There's Schedule 1, 2, 3, 4, and 5 drug substances. Here's some examples of them. Schedule 1, high potential for abuse, no medical use in the United States. Heroin. The patient is not going to be prescribed heroin or peyote. Schedule 2, high potential for abuse, methadone, morphine. Schedule 3, A little less potential for abuse, codeine, not more than 90 milligrams of codeine. Schedule 4, low potential for abuse, Xanax and Valium. And Schedule 5, low potential for abuse, Robitussin AC. So it's 2 factors, parenteral administration and a controlled substance. Okay, that completes this video. If you have comments or questions, please feel free to contact me. For more information, see the link to the complete document posted in the video description. This is an overview. It's not everything, all the changes. Remember, there's also part 1, which talks about key component, and there will be, hopefully next week, part 3 for changes to specific categories of codes. If you would like to purchase a copy of these slides with this video, give me a thanks of $5 or more and comment with your email, or you can send your email address to here, and I will send you the PDF after you give the thanks. If you enjoyed this video, please give it a like and subscribe by clicking on the picture in the lower right-hand corner. And here again are the books I have written. These are available on Amazon. We have Evaluation and Management Coding, which had not yet been updated. The ICD-10 CM book, which has been updated for 2023. ICD-10 PCS book, which has been updated for 2023. And here is the link to the books. Thank you so much for listening. I hope this was helpful.